You're listening to the 40 Fit Radio podcast, dedicated to the 40-plus community. Join us as we discuss the truth about fitness and health using science, reason, and the experiences of our host and content experts. Welcome to the 40 Fit Nation. So welcome back to the 40 Fit Radio podcast, and welcome back to the 40 Fit Nation. And today we're going to talk about, well, first of all, this is Coach D, and I am here with Coach Trent.
Hey.
And today we're going to talk about strong shoulders, boulder shoulders, strong shoulders, and the concepts that relate to shoulder health and how you can build a strong set of shoulders that can function way into your elder years, and that's the goal. And so today's episode, we're going to do this in probably a two-part episode based on how long each podcast goes, and this one's going to be covering basic shoulder concepts so that you can get a better feel on the anatomy and physiology of the shoulder, which is the structure of the shoulder. And I think it's important that you understand, as part of the listening audience, how the shoulder moves and why it does what it does, and then that gives you a better feel for understanding how the shoulder can be injured and how it also can be trained through injury or gotten better for function, and that's key. So,
yeah, is there any joint that is hurt more than the shoulder? I mean, it just seems like colloquially, every guy over the age of 30, quote unquote, threw out their shoulder if they played sports at all.
Yeah,
at some point.
Yeah, I don't know. Let me think about that. In my clinical practice of approaching 30 years, 29 years already, if I think about just the volume of injuries that I've treated, I would say that shoulders and spine go back to back, probably. They run a close first and second always. So shoulders and low backs specifically, lumbar spine, lumbosacral spine, probably run a close first and second always. And then after that, you would have the knee. The neck would be in there too, but then you would have the knee, and then you would have the wrist and hand, and then you would probably have the foot and ankle. The hip I would kind of throw in there too, probably somewhere around right after the knee, and then you've got elbows probably after that, and then earlobes. So earlobes,
the face.
Yes.
Oh, you can't do anything about the face.
No,
sorry.
Earlobe injuries, terrible injury.
You're at the wrong specialist.
Yeah. But it's the shoulder's The thing about the shoulder is you use all your joints every single day. That's obvious, but the shoulder gets a lot of movement in most individuals all throughout the day, from the time of waking to the time of going back to sleep, and even during your sleep sometimes you're moving your arms around. So we're going to talk today about the basic anatomy and physiology. And so we'll get a little deep into the weeds today, but I'll try not to get so sciencey and technical that it's not easy to follow, and that also it's practical knowledge that you guys can use so that you better understand the shoulder. So as we move forward in the shoulder, let's talk a little bit about the bony structure of the shoulder. So the shoulder is made up of several different bones. It is made up of the scapula, which would be considered your shoulder blade. It's a triangular shaped bone that sits on the back of your rib cage. And actually articulates or rubs. Articulate means to move. It articulates against the rib cage in a soft tissue methodology. In other words, there's no true bony attachment there on the rib cage. It just kind of floats on the rib cage, on the undersurface, the infrascapular fossa or surface. And then there's a muscle group there, and then there's layers of fascia, and then there's the ribs and the muscles and the fascia on the ribs and the surrounding musculature. So it floats on there, and it is held in place on the rib cage by a group of muscles that then have, I like to call them outriggers, which are basically just tendons that go and pull and push and rotate and serve different functions for stabilizing it and also allowing it to move.
Yeah.
Within every joint, there are two basic principles that we always want to review, and that is that the joint has to have a certain amount of stability, and we talked about this on our mobility podcast, and a certain amount of mobility. So it's got to have both. It can't be too stable to not be allowed to move. There are some joints that are like that, like the sacral joint is a very, very
it's fused.
The iliosacral joint
right.
is I mean,
sense.
the iliosacral joint, it has an articular surface and it has cartilage. So if it has a surface of articulation and cartilage, we know that there's movement there.
Right.
There's not much movement there. It's very conjoined. In other words, there's a lot of surface area contact. It's really designed to be more of a stability joint than it is anything else. But it does have some movement, a little bit of movement. And then on the other end of the spectrum is the shoulder joint that has much less articulating surface, especially at the glenohumeral joint. We'll talk about that in just a second. And so it has these large degrees of freedom that we're going to talk about. Notice it has all this mobility, but it's got to have a certain amount of stability too, because those two principles go hand in hand, the yin and the yang.
Yeah.
You've got to have both, or you get a joint that is unstable or too stable, and then you get injuries in the area.
So that free-floating nature of the scapula is going to be important when we get to training the shoulder in the next episode.
Absolutely.
So that's one thing to particularly highlight about the scapula is this free-floating nature, because that allows us to use exercises such as the press without damaging the shoulder, allows us to strengthen it. So we're going to get into that later.
There's certain ratios of movement. We'll talk a little bit about the biomechanics of the shoulder without getting too crazy, just anatomy and physiology too deep into it. But yeah, I mean, there's a certain amount of movements of freedom and a certain amount of stability that's required. So we have the first bone that we're talking about is the scapula, the shoulder blade, and it rubs against the rib cage. So the rib cage would be considered part of the shoulder joint in the sense that it's part of what we call the scapulocostal joint in that area there, okay? The next bone that we're going to talk about is the humerus. And the humerus is the upper bone of your arm. It makes up that portion between your shoulder joint and your elbow. And there's one bone there, and that bone attaches at the shoulder joint, and it attaches at the elbow joint. At the shoulder joint, we call that the glenohumeral joint because it attaches or connects with the glenoid, which is a fossa, kind of a concaved recess of the lateral portion or the outside portion of the scapula, the shoulder blade.
Yeah.
So the shoulder blade has a little fossa or a little recessed area that almost looks like a little crater, and it's shaped like an egg almost in regards to its ovoid or non-circular shape, more of an ovoid shape. Mm-hmm. And then it has some cartilage in it, and the humerus, the head of the humerus, which is a ball, and the glenoid, which a lot of people think it's a socket. It's not actually a socket.
Yeah.
I think about it as this way. If you look at a cup, if you looked at a round bottom cup with just a little bit of a flatness on it, on the bottom of it, so it could stay flat, from the side on a table, if you looked at the cup and you looked at it sitting on a curved saucer, and then you took that and you turned it sideways, that would be the glenohumeral joint. So it is totally different than a true ball and socket joint like the hip.
Right.
So there's a big difference in its anatomy, in its biomechanical structure, and the amount of stability versus mobility that you can have in that joint.
Yeah, so the scapula, the edge of the scapula kind of makes a little hook almost, right, that we would call the acromion process. And that hooked nature creates a kind of a sort of an open claw sort of looking thing that the head of the humerus fits into, right? And that's when you're saying that fossa's underneath there. But
the fossa sits there, and the humerus, the humerus bone sits into the fossa. And the way it is attached to the fossa, we'll talk about that in just a second, but it's attached by ligaments and tendons. Those are the attachment points. Mm-hmm. So it's not so good and press fitted like the hip joint that it actually has kind of a really conjoined or real circular kind of ball and socket sucking type. Do you like that little?
I like that sound effect. Yeah.
Like
These
that.
are all performed live. There's no soundboard here.
No, we don't have a sound guy or anything. I did that with my mouth. It was pretty amazing if you ask me. But there's that kind of a sucking in of that joint in the hip, and that in itself kind of holds that hip joint together, which requires, you still have a lot of ligamentous support of the hip joint and a lot of musculotendinous support, but it's a much more stable joint.
Right.
So the scapula, like you just mentioned earlier, also has a little hook that comes over the top. And you can imagine that this little hook serves several different purposes. Number one, it's the roof of the joint because it hangs over the ball of the humerus.
Right.
So it's kind of the roof. It protects the joint from something that would fall down and it couldn't hit the top of the humerus. It also helps to limit some degrees of freedom, so it creates some stability. But it also has other ligamentous structures and support structures which connect to it, which gives stability to the joint, okay? Coming off the front of the scapula is another little bony process that kind of sticks out, and it's called the coracoid process. And the coracoid process is right there in what we call the triangle of your shoulder, and it's where your biceps tendon attaches, your short head of your biceps tendon, and several other muscles. The pec minor attaches to that area, and so it sits right there in the front of your shoulder. And it again serves for a ligamentous purchase. In other words, the attachment of ligaments that help the shoulder support itself. And that's just another little bony process off of it. But the scapula, the shoulder blade, has these different surfaces and different bones that come off of it, and they're all one piece put together. The other part of the shoulder joint that we have to talk about would be the clavicle. And the clavicle is a strut. So if you think about a car, if you think that your head and your trunk is the body of a car, it's the main frame of the car.
Yeah.
And then coming off the car, okay, are the wheels, and the wheels have struts and axles that come out to the sides. And the struts control how the wheels go up and down, in and out, back and forth, rotate. Well, your clavicles do that. The collarbone, it's right there at the top of your chest wall. The collarbone comes across, and it goes from your sternum over to attaching to the acromion at the acromioclavicular joint. Okay?
The AC joint, right?
AC joint, that's right. So you've got the AC joint, the glenohumeral joint, and then the scapulocostal joint, which make up, in a general sense, the shoulder joint, okay? So the clavicle is a strut, and it creates stability of that joint again. It helps to control how that scapula, that shoulder blade, is going to move up and down the rib cage, and it also provides protection and is a good point of purchase or connection for a lot of ligaments that support the joint. It also is where part of your pec major attaches, so the pectoralis muscle of your chest, okay? Your chest muscle, chest wall muscle. And so those are the basic bones of the shoulder joint. So let's talk a little bit about the muscular concepts. And when we talk about muscles, remember that muscles' primary purpose are for movement. They are there for movement and support and stability too. A tendon's purpose is to connect the muscle to bone, and a ligament's purpose is to support bone to bone. So ligaments are what we would consider passive structural supporters or elements. In other words, they don't contract. You can't contract and relax a ligament. The way you contract a ligament, or the way you tighten or loosen a ligament, is to pull the bones apart, it tightens it, or put them back together, it loosens it, okay? Well, in your shoulder joint, let's talk about the basics, what holds the basic structure of your shoulder joint together. Your shoulder joint is held mostly together by all of the passive elements. That would be the shoulder capsule joints. There's these ligaments, and it looks like the boot on a tie rod end, basically. And for you mechanics and you gearheads out there, you'll know what I'm talking about. It encases the entire glenohumeral joint, so it encases the entire cup and saucer joint there, and it's a ligamentous collagen structure. It's very, very strong, very durable, and it holds everything together so that the shoulder joint and its fluid that's inside of it, which is called synovial fluid. There's a lining on the inside of the capsule, and it's a synovial lining, and it constantly is producing liquid, and that liquid is lubrication because, as we all know, lubrication,
it's everything.
It's everything. So that's right. So inside that joint, we need it to be well lubricated. The other thing is that what stimulates the production of synovial cells to produce more fluid is movement. So that's why joints need movement. They need movement, number one, to keep the articular surfaces, the surface from sticking together and becoming very sticky and degenerative and avascular and less healthy. But also, we move the joint and it becomes better lubricated. And that's why movement in joints is so important for warming up and everything else. So we've got the supportive ligamentous structures of the glenohumeral joint. And then we've got also other ligaments that are outside the glenohumeral joint that are part of the acromioclavicular joint. We've got the conoid ligament, and we got the trapezoid ligament, which is made up of two ligaments. And they support the clavicle and the scapula together. And so we've got several other ligaments, transverse humeral ligament that holds your bicep down, that are in the shoulder. It's not important that you know what all these ligaments are. It's important you know that when you dislocate your shoulder, it's not necessarily because you tore the muscles. It might be because you have a muscular tear or injury, but it's because the ligaments, there was enough force produced in that joint that it pushed the ball out of the socket, okay, or the saucer, off the saucer, and it could have very assuredly torn the ligaments of the joint.
So there's none of these bony structures that we've mentioned are directly touching each other in a healthy shoulder. We've got these ligamentous attachments, but there's a lot going on in a small space.
Yeah, very much.
And in fact, and I think this is something we'll get into a little bit later, but people have varying degrees of room, if you will, within that shoulder capsule, right?
Oh, sure, yeah.
That glenohumeral joint.
Yeah,
and that can determine your stability or health of that joint.
Absolutely, and we'll talk a little bit about some of those factors. What factors promote stability and mobility in a healthy or an unhealthy shoulder joint? So we've got the ligaments, which are the underlying passive structures. Then we've got all of the musculature. Well, let's talk about this first. Let's talk about some of the other structures inside the joint itself that help. We've got articular cartilage and hyaline cartilage. We've got this thing called the labrum, and it looks like the borders of a skating rink that's kind of like a helodome, a racing rollerblading rink, and it's curved and it has a meniscus type structure just like the knee. And so the labrum is a border of cartilage that goes all the way around the outer borders of the socket of the glenohumeral joint. And then as it gets closer to the middle of the joint, it becomes thinner and thinner and thinner and thinner. So by its very shape, as a meniscus, it keeps the ball in the socket the way it's supposed to be held. And so you've got that articular cartilage. It's very avascular, meaning it has very poor blood supply. And it also is very aneural, meaning it has very little nervous supply. So you can be injuring it and not know it. And that also means that it heals very poorly too. Labral tears are common, one of the common injuries in athletes and some older clients that have just had a lot of labral wear and tear.
Sure.
So, but the articular cartilage helps to support that joint. And the hyaline cartilage, the cartilage that's actually on the surface too of the fossa, which is the saucer, the cup, not the cup, but the socket. And then also on the surface of the humerus is hyaline cartilage. And that's actual joint surface cartilage. It's a layer of cartilage that helps these two bones rub together without rubbing bone on bone. Your bones don't actually rub together bone on bone. If they did, that hurts. And that's when shoulders become arthritic, or you get maybe another condition called osteoarthritis, is when it's bone on bone, then you have a lot of nerve endings in that subchondral bone, and the nerve endings then stimulate a pain response, and it's very, very painful. That's when your shoulder becomes very painful inside the joint. So we need that cartilage to be healthy, and motion is lotion for joints, and that's why we need to be exercising these joints and moving them. But also, sometimes athletics or too much overuse can cause this cartilage to be worn out and torn. So you've got the passive elements that support the joint structure. And then you've got all the active elements. And those are the elements that we're going to impact change on joint health by loading the cartilages, because now we know in the literature that loading cartilages, that moving the joint creates better health in the joint. It improves lubrication. It improves the cartilage density and thickness. It improves the mobility of the joint. And it stimulates the receptors of the joint to allow the joint to have better ability for use, okay? But the thing that we can really impact the most of when we train shoulders, those are the muscular and tendon elements, okay? We can really impact the muscular and musculotendinous part of the shoulder complex. And so when we talk about shoulder muscles, we, as a physical therapist, I think about the shoulder muscles really in two different groups, and we have been, in some ways, I guess you would say, called out on this because we think about the shoulder almost compartmentally. But I think it's important for an assessment or overview and general understanding of the shoulder that you do understand that there are two types of groups of muscles in the shoulder. They're what we call the primary movers. They're the big muscles. So that would be the deltoids, the upper traps, the rhomboids. These are bigger muscles. The bicep, the tricep. These are bigger muscle groups that are what we call primary movers of the shoulder, okay? And the serratus could be considered a primary mover too. And then serratus anterior. And then there are smaller muscle groups, which we would then consider more secondary movers or stabilizers. Now, all these muscles, it's not to say that by calling one group secondary, they're less important. They're actually more important probably. And it's not to say that calling one group more stabilizers and one group movers, that they're not movers and that the others aren't stabilizers.
Yeah.
It's just to say from what we figured out through research, that those are their primary functions, and so that's how we nomenclature them. That's how we call them.
Right.
Is by being a primary mover or a secondary stabilizer or secondary mover. So the primary movers are those big muscles. They create the big movements of the shoulder, okay? The secondary movers or the stabilizers and the biggest group that everybody knows is what we call the cuff muscles, and the rotator cuff muscles. The reason why they're called rotator cuff muscles is because their primary function is to rotate and to stabilize the humerus in the glenoid, okay, or in the fossa, in the joint. And those would be the infraspinatus, which sits basically on the bottom side of the spine of the scapula on your back, the supraspinatus. We call them the sits muscles. I'll do them in order. Supraspinatus, infraspinatus, the teres major, and the subscapularis. Those four muscles are what we would call, in a garbage can term, the rotator cuff muscles. Now, when someone says they have a rotator cuff tear, we don't know which muscle they've torn. Well, which muscle's torn? It could be a full thickness tear, a rupture of the entire cuff. It could be the supraspinatus, infraspinatus, teres, subscapularis. And I've seen injuries like that. Or it could just be the supraspinatus and infraspinatus, or just the supraspinatus, or one or the other.
Right.
So it could be individual muscle groups. But those muscles, they basically help to stabilize the humerus, the bone of the upper arm, into the socket. And the reason why we call them stabilizers is because they're smaller muscle groups and they have a shorter length. So when they contract within their action of work, they have less influence in regards to the degrees of freedom of the shoulder, but they don't have less importance.
Right.
They're extremely important. And their primary job is to pull that humerus down in the socket when we get and suck it to the socket when we get ready to raise the arm overhead in front or out to the side or to the back. So anytime we really get up above about 60 degrees, then they are really, they work really hard in the bottom end of the range of motion, and they have to contract. Because they start as the arm starts to go up in the air, as the arm is started to be raised up, they pull the ball down into the socket and hold it so it doesn't migrate up and hit the undersurface of the acromion,
right?
What we call the subacromial space.
Yeah, so you can see how in athletics that any sport that requires a lot of overhead work is going to really work those rotator cuff. You think about like a pitcher, right? It's very common to see rotator cuff tears here because you get a lot of velocity and overhead movement.
Yes, yeah, absolutely, and
very quick forces.
Yeah, and what a lot of people don't understand is the The initiation of the rotator cuff early in the range of motion within the first 0 to 60 degrees, and 0 to 90 degrees actually, but 0 to 60 is that kind of really important range, is what sets the shoulder joint up for the rest of good movement overhead. If that is lost in the bottom end of the range, in other words, if there's a cuff tear and the humerus is not being held down into the socket like it needs to, it rides up. And then when you start to go through the range of motion, you get an early elevation by the upper trap and by the big movers take over. And what happens is they overpower the small movers because they're not working right anymore, the secondary stabilizers. And then as the shoulder is raised up overhead, there's a grinding or an impingement that occurs like we talk about in the physical therapy and strength world. But when the cuff is being used, and let me just say this, when you go to move overhead, if you have an unhealthy cuff, even with good lifting technique overhead, you can still impinge. You can still impinge. That's important to recognize. Because we talk about the fact that, I mean, we, you know, as strength coaches, we've really harped on the fact that the overhead press is an effective overhead strengthening exercise to improve the shoulder strength and function for use. And it is. I think it's the best exercise. And I use the overhead press in its varying degrees of use and modifications and accessory exercises to it also in a clinical sense and in the gym too with my patients and my gym clients. But if you have a cuff injury that's a significant injury and early in the range of motion, in the biomechanical range of motion, there is a lack of downward movement of the humerus in the socket, and the humerus is allowed to ride up, it gets caught. It almost gets impinged or stuck in between kind of the more upper surface of the glenoid, of the socket, and then it kind of gets wedged in there under the acromion. Now, there is a force coupling model that we follow here. And so the force coupling model is between the secondary stabilizers, the rotator cuff musculature, and those big movers. And the force coupling model helps to offset that when it occurs. But it could be that early in the range, there's a little bit of upward elevation of the shoulder that we don't need because the big muscles sense the shoulder's not moving right. I've got to help more. And when that occurs, it drives it up into the socket where it's not supposed to be. And it doesn't get down like it's supposed to be, and then impinges or wedges up underneath there. And then as you go up to raise overhead, there's more pain. And then you say, overhead lifting causes pain with my shoulder. No, that is merely a symptom to the underlying root cause.
Sure. Yeah.
And the root cause is the secondary musculature are weak. Okay. Now, what we find is I have seen lots of athletes, and I'll tell you where I've seen this a lot of times is in bodybuilders, because they do so much isolated work. I've seen bodybuilders with huge traps and huge deltoids and big primary movers. And I mean world-class, Arnold, Olympia bodybuilders I've treated. I treated for years. I treated one of the top 10 female bodybuilders in the country that went to the Olympia, I think over 10 times.
Wow.
In her 50s, she was still in the Miss Olympia. And but those athletes have very large muscle bellies and very strong primary movers. But if they get a cuff injury, what we don't see is that the underlying stabilizers are actually weak, or they're not functioning mechanically because they're torn in half, potentially, and mechanically the joint's not moving right. But the big movers are still trying to do the motion that they need to do. And they do actually impinge then. So when the rotator cuff is unhealthy, overhead movement can be damaging if we don't address the rotator cuff weakness and what the problem is.
Yeah, that's interesting. So let's unpack then. So the argument that's made in Starting Strength that advocates for the press as a strengthening movement, and we'll have to assume a healthy shoulder, right? We'll assume no pathology, no torn,
no cuff injury,
Yeah. So the argument is that going back to what we highlighted earlier, which is that free-floating nature of the scapula, is that in an overhead press movement properly performed, the scapula rotates upwards along with the shoulder and actually kind of pulls away as the traps are engaged at the top of the press during that shrug movement that we do, which effectively opens up space in that glenohumeral joint.
It opens the roof. It pulls the acromion away above from the humerus, and so it creates more space.
Pull
That's right.
The scapula back away from the joint.
We call that scapular adduction. The scapula comes closer to the spine in the back, so it's like getting a big chest. You squeeze the shoulder blades back, and then as you're raising the shoulder up, the upper traps then, after about 60 degrees to 90 degrees, the upper traps start to recruit more, and they pull the scapula up, and along with force coupling of the rhomboids and the serratus anterior, okay, those are the force couples. There's three forces. The serratus anterior, the rhomboid, and the scapula create a rotational effect of upward or superior rotation, adduction, and elevation.
Yeah. Okay.
Those three movements are combined. Upward rotation, so the fossa, basically what happens is we turn the saucer upwards towards the sky.
Right.
And then we pull it up, and then we pull it in. And so there's three motions. We call that the force coupling. In the there's force coupling that occurs there. And by the way, I know a little bit about the shoulder joint. I did my thesis and my doctorate work on the shoulder.
Oh, really?
And on impingement syndrome. I wrote about a 50-page paper and did a thesis on shoulder health, and at the time did a multivariate analysis of the literature review and looked at all the rehab programs and the strengthening exercises and the biomechanics and the force coupling model, and then wrote a paper on that. So I don't know, we might even be able to make that available. I think I have it in a PDF.
If you've got it, we'll post
and it is very boring reading, but it got me the certificate on the wall. So, but so that force coupling is very, very important.
So to kind of tie that into what you were describing earlier, we would call the reasoning or the logic behind the model in starting strength for the press is that allows the primary movers do their job, and the joint functions in a healthy manner to prevent those secondary movers from getting impinged. However, to your point, if the secondary movers have any damage, then we can still have problems.
They predispose the injury.
But in a healthy shoulder, the press is a good, properly performed.
Yeah, I think I would say it this way, and I mean, I think starting strength has best elucidated this point, but I don't think it's specific to starting strength. Let's just say it this way. For upper body strength, the barbell or dumbbell overhead press in free weights is probably the most effective overhead strengthening movement that I have found as a coach and as a DPT, as a doctor of PT, as long as the cuff musculature are doing their job in the portion of the motion, the movement cycle that they should be doing, and there's no significant injury to them, and then the primary movers can produce, the primary movers are the real strength of the shoulder joint, and they can produce that maximum force capacity for heavy lifting overhead. When the secondary movers are the stabilizers, the cuff musculature of the joint, which we could draw an analogy to the small, tiny little stabilizing musculature of the spine and the big erector movers of the spine. There's a very strong correlate there. The body uses these kind of correlates all over because it figured out that, wow, this works. Yeah. We have little muscles that are stabilizers, deep stabilizers, and you're usually right on top of the joint. And then you have the bigger muscle groups, which actually create more of the movement of the joint. So you got stability, mobility, like we talked about. These concepts that are very, very good constructs. But if the cuff has been damaged and there's not enough stability in the joint to pull the humerus down, then it could preclude the joint from being able to move correctly, cause pain, cause damage to the joint. And we've got to find that problem early before we start loading heavy, because here's what can happen. The big movers can keep pushing on, and at first it might not be very painful, but every time you do it, you're grinding that cuff. And so there are some tests that we can do. We not only want to look at strength, but we want to look at the endurance of that musculature too. Can the musculature tolerate multiple reps over time? And then we manual muscle test and test the cuff musculature. And we should see a good strength ratio between the big movers and the little movers. So yeah, those are important concepts. So in the shoulder joint, we've got the bony structures. We then have the passive stabilizing structures, which are mostly made up of the ligamentous capsular tissues. And then we've got the active supporters and movers, which are made up of the tendons and the ligaments. Then we've got the active primary and secondary movers, which are made up of the muscles and the tendons. Okay, so we've got the muscle groups, and then we've got the tendons that attach the muscles to the bone. So that's in a nutshell. This shoulder joint can also be at risk for injury due to other anatomical or predisposed, I guess you would say, genetic traits. And that's what we're going to cover next episode. Because, man, we're almost 40 minutes into this podcast, and we've just talked some very basic anatomy and physiology of the shoulder joint. So next episode, we're going to talk about some of the things that might predispose the shoulder to injury when it comes to specific genetics and the way that you're built as a lifter or as an athlete, whether you CrossFit, you swim, you do triathlons, you do yoga, you do barbell lifting, strength training, whatever, or other sport. And then we're going to talk about those categorically. And then in the following episode, because this is 3 episodes, brother. In the following episode, we're going to talk about the exercises that we use, the strength training exercises that we use as the primary exercises to get the shoulder strong and healthy. So,
yeah, as well as some for those that lack mobility in the joint, that need to improve that in order to facilitate doing those strength exercises. We'll cover some mobility work that you can do as well.
Yeah, absolutely. So, man, thanks, guys, for joining us today on the first of a 3-part episode on shoulders, getting your shoulders strong. And if you want to reach out to us, you can do that on Instagram at 40Fit Radio. Trent's is at Marmalade Cream. Mine is at DL Deaton. You can also go to Facebook, and we go to Facebook community, Facebook
40Fit Masters Community.
40Fit Masters Community. There we go. And then you can go to 40fit.com. Or you can also go to our gym site, which is ftwstrength.com, and you'll see the 40Fit tab there, and you can go to 40Fit Radio and find out more information about us. Man, we appreciate you guys listening. Share our podcast, give us some good reviews, or just give us a review so we can improve. And thanks for joining the 40Fit Nation.